This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson. It's my pleasure to have with us tonight Metra Gipson. Welcome, Metra. Nice to have you with us.
Thank you, Dr. Robinson.
Well, you know, with a lot of things going on in the world, there are a lot of complexities, and right now you're you're the guru about something that's very complicated. Why don't you talk about what you do and what's going on?
Okay, certainly. I actually am a consultant with Optum 360. I'm currently working with Navicent Health on their transition to ICD-10. So ICD-10 is actually the new diagnosis coding system that all of the healthcare entities are actually transitioning to and preparing for, and it's going to be effective on October 1st of 2015.
Now, one reason to talk about this is I don't think people really understand. There's a lot of discussion about the American healthcare system, and people think, well, it costs this, or this is what's happening, or this is what's driving the person's individual health care. But one of the most important things are the way things are coded. Why don't we talk about what coding is and how that's accomplished and what that means for, say, a doctor or a hospital, or more particularly the medical center at Navicent Healthcare or the Coliseum. What does all that mean? What is that? What is
Okay,
coding?
sure. I will do my best. I am not a coder,
Yes.
but I will definitely try to speak to that. The coding system is how we actually, the nomenclature that's used to represent a person's medical condition. So we use it for billing, we use it for quality, we use it for research. So that way we have a standard method of really communicating, you know, if someone has diabetes, if someone has some other kind of medical condition, then the code is how we actually define it. Today what we use are the codes that are ICD-9 codes.
So this is a big deal.
This
So
is a
it's
big
like
deal.
changing. It's like changing from speaking English to Spanish. I mean,
Yes, it
the
is.
code. This code change is a huge, big deal.
Yes.
And it's a government-mandated arrangement that's taking place. Is
Absolutely.
that correct?
That is correct.
And what is the difference right now between an ICD-9 and an ICD-10 code? What is or system? What is the difference?
Sure, there are a lot of differences. There's a difference in how they look. So for example, the ICD-9 codes today, they mostly start with numbers. The ICD-10 codes are going to start with alpha characters, so like E, Z, for example, would be the beginning characters. The length of the code, so now when you see an ICD-9 code, you typically see one which is from 3 to 5 digits. With ICD-10, it's going to be from 3 to 7 characters long.
So it's getting a lot more complicated. And so
yep.
one of the things that needs to be thought about when we examine the American healthcare system is how important these codes are, and some of the, I guess, the difficulties and virtues of change. Now, the ICD-10 is what's being used in Europe. Is that correct, or where is that used exactly?
It's actually used by almost every other developing nation except the U.S. So we are behind in terms of making this transition.
So where did ICD-10 start? And do you think it has advantages over ICD-9? And if so, what are those advantages?
Well, it actually was developed by, I think it was the World Health Organization originally. Actually developed it. And definitely there are some advantages. With ICD-9, some of the issues with it are that it's out of room. We don't have the ability to add any additional codes to it. It can't keep up with medical advances, so advances in treatment, advances in technology, we can't reflect that in the codes. With ICD-10 as well, some of the other benefits we're going to start seeing is some greater specificity in communicating and reporting a patient's medical condition. So there are definitely some significant advantages.
Now, there are some disadvantages too, is that correct? Well, could you think of any disadvantages that might be present?
Well, you know, one of the disadvantages could be the number of codes that are out there. for example, right now with ICD-9, I think there are about a little over 20,000 codes.
Yes.
With ICD-10, there are going to be a little over 140,000 codes. So you'll hear a lot of people talking about the difference in the volumes, but I think that, luckily for most physicians, they really typically use a core set of codes for most of the patients that they treat. So, but that's definitely one of the things that's complicated about it.
So we hear on the doctor's lounge, I mean, I'll say that, this is for the people where the doctors hang out, they drink coffee, they eat too many donuts,
Yes.
they get a little tubby sometimes, and they squeal sometimes, they talk about whatever you talk about. And there's some complaints about ICD-10
Okay.
and how difficult it is to do this. And just to discuss that, I mean, this is a big deal. Is it an expensive thing to change? And how burdensome is it going to be to do this coding? Any comments about that?
I can share a little bit. It can be a very expensive change, but I think there are things that you can do to manage that. The CMS actually offers a lot of tools and resources that are free right now that are available. There are a lot of webinars that physicians can participate in that would be free. And then with Navicent Health, we're actually going to be providing a lot of free education and training to physicians to really help and prepare them to make this transition.
So one of the things, just to squeal slightly about this,
Okay.
is that the docs would like to practice medicine. That's what
Yes.
they'd like to do.
Yes.
And the amount of distractions caused by coding it's becoming extraordinarily burdensome. So if you talk to a doctor on the street and they're doing their own coding, it's a big leap to do this. And even if the courses are free, many of the doctors are so cranky, and maybe I'm one of them, going through and trying to do this, it's really quite a task. And what happens if a mistake occurs in the coding? Let's say you have a clumsy physician, and he's trying to let's say he has a dog bite he's treated,
Okay.
and he's always, for the dog bite, he's always put, 3, 4, 6. And it turns out that he has to be more specific than that. It turns out it's a dog bite from a small corgi. A small little corgi has bitten someone's foot.
Right.
And if you don't put that down and you don't do it in the correct fashion, what occurs then? I mean, if there's an error in the coding, what would happen?
If there's an error in the coding, what you probably would see is where the insurance company would be asking you to provide clarifying documentation or provide corrected documentation to support that. So it would increase the communication that you're getting from the payers.
So an error in the coding could be a pretty big deal. And if the coding gets to be pretty complicated, it would, in fact, cause lots of issues. Could a person be accused of any illegalities if they inadvertently put down the wrong kind of dog bite? I mean, or whatever. I mean, what would
Right.
happen? I mean, you just really screwed your coding up, and somebody said this is crazy. Any
Right.
comments?
So I guess your question is there a chance that you could be accused of fraud and abuse? And, I think that that's something that initially with this transition, I don't foresee that happening necessarily. But just like with everything, there's always a potential for that to occur.
One of the things that we spoke about a little bit, the plan was to institute this. I believe this the government mandate to change the coding was part of the Education or the Healthcare Reform Act of 2009 or so. Was that in that interstices of that when healthcare reform came in? Is that part? That's the reason that we're having this coding as it is.
Actually, it is. It's a part of that, and also part of HIPAA as well.
So the government has mandated the change.
Exactly.
And that's sort of a universal thing. Insurance companies have to do the same thing. Everybody. In the country. So if you're using the wrong code, I mean, there won't be any compensation. It'll be a catastrophe. So a tremendous thing happening right now all across the country, where people are trying to make the transition to the new code. Is that a fair statement?
That is a fair statement. There are only 2 exceptions to that. So workers' comp are not making the transition, and auto insurances do not have to. They can, but they don't have to transition.
So if you're in fact, if a physician had this dog bite, and let's suppose it was a veterinary assistant that was whatever was whatever was a workers' comp injury, and the wrong code was used, the ICD, would it cause a lot of confusion, would it not?
It could. That again is some of the work that we're doing to try to prepare for the transition so that we can easily identify the auto and the workers' comp payer cases, so that we can kind of separate them out and they can be coded with ICD-9 just like they are today.
Well, all right. Now we'll discuss whether that's the good points and bad
Right.
points. Obviously,
Yeah.
some good points.
Mm-hmm.
But just to continue on this, this was held in abeyance for at least a year. Is that correct? When
Yes.
When was this supposed to go forward? When was this supposed to happen?
There's been at least 3 delays of
Really?
ICD-10 that I know of.
3.
3, exactly.
When was it supposed to have
Let's
been
see.
instituted?
I'm trying to think back. I think the original date was, I believe it was October 1st of either 2012 or 2013.
Yes.
So organizations have actually been working towards this transition for a number of years and have dealt with it being delayed for at least 3 times.
And why did the delays take place? Why were these delays?
The delays occurred because a number of stakeholders felt like they were not quite ready for that transition.
Yes,
So
yes.
some of them providers, some of them maybe even other entities that felt like, that they just were not ready to do it and
Yes.
wanted to slow down. And then in addition to that, there were so many other initiatives that were happening at the same time
Yes.
that they wanted to also focus on those as well.
How does the coding, if this is a universal coding, I mean,
Mm-hmm.
there are 140,000 sort of, I guess, different ways to code different disease processes, and this is a worldwide code. How does it work? Just to name a country, I'll pick India.
Mm-hmm.
I mean, if you're there, maybe the healthcare system is not as advanced in the U.S. Or what happens if you're a country doc and you're trying to code something? Are there errors? I mean, how well is this working in the rest of the world? I mean, with such a complicated kind of coding apparatus.
Right. I think the difference in how other codes use it, they really use it to report morbidity and mortality. We are one of the only countries that really use it for reimbursement purposes. So that's the distinction.
So just to go through this, if you're in another country, it might not be so burdensome. If you're just going to say it really is why you died,
Yes.
it might not be so hard. You died for code 206, and that might be the only interchange that occurs in another country.
Could be.
And what about Western Europe? How hard? I mean, are there countries in Western Europe that use this as their reimbursement arrangements? How has it worked out for them?
There are no other countries that I'm aware of that use it for reimbursement.
Okay, so we've established that this incredible code that's out there with 140,000 things that it's been touted. This is like a world-class. The rest of the world does it. We're going to be in advance, if you want to phrase it that way, of every other country in the world, and we're sort of sailing the ship into slightly uncharted waters. Is that fair? Maybe I don't want to sound mean about this, but I mean,
I guess you could say that, but I think there's so many advantages as well with making the transition, and even though there is some concern about how we use it for reimbursement, I think over time it will actually make it improve that process for us, because you won't have where your prior authorizations or medical necessity cases don't actually match up with the claim. And I think once we start doing that, hopefully over time, what you'll see is less denials, less requests for additional information, less requests for needs for medical necessity validation and things of that nature.
why don't you talk about what you just mentioned? I mean, maybe the public just doesn't understand how complicated it is to receive health care.
Sure.
I mean, so your physician says, well, I think you need to, come in and have your big toe amputated, whatever, your right big toe amputated.
Right.
And to get that accomplished, there has to be an approval of an insurance provider.
Yes.
Is that correct?
That
How
is-
does that work?
That is correct. For most cases, insurances, they will typically have certain cases that they want you to actually call, and as you said, get prior authorization. And usually that just depended upon, what the procedure is, as well as, what's the diagnosis or the condition that's the reason for that procedure. And then once the service is delivered, the claim gets generated, claim gets transmitted to the payer, and then for the payer, it also goes through an adjudication process on their side. There really are some administrative requirements that you have to meet as well to make sure the person did have benefits, make sure they're covered, and then if so, then at that point, a provider would typically get paid for the services that have been rendered.
And so this whole system is pretty complicated.
It
It's
is
not like the country doctor sort of looking after the sick child. There are all these complexities to it.
There are.
And so the anticipation is that when this occurs, when the new coding system,
Yes.
things would go in a smoother fashion. It would be quicker and easier to get this accomplished.
Initially, of course, there will probably be some bumps, as with any change that occurs.
Yes.
But over the long run, we would expect it to level out and to smooth the process, hopefully provide the insurance companies as well as other providers with so much more detail about the patient that it will address some of the issues that you may see from medical necessity or what have you currently today.
There's a lot of discussion now about changes in the American healthcare system, and obviously there's substantial shortfalls or things that need to happen. And everyone would be in favor of a simpler, easier system. I just hope this coding is going to give us that. What happens when there are more or less 320 million people in the country? So it's a huge deal. I believe the date is October the 1st, is that correct?
Yes.
320 million people, their health care is subtle. The computers have been speaking Spanish and they're going to switch to English or vice versa.
Right.
Is that correct? Are people ready for trouble or difficulties, or is there going to be some kind of snafu about this?
Well, we're actually, some of the things that we're all working on right now are really just trying to put mitigation plans in place. So, we're trying to make sure that all of our systems have been remediated, that they can accept the new codes that have a larger character length requirements. We're trying to do some testing with the payers so that we can see what kind of responses, make sure that we can transmit claims. So we're doing a lot of work in terms of education of just overall staff, education of providers, looking at systems, looking at workflow processes, planning for that actual cutover process to make that transition. So, and by doing so, we hope that will, make it a little less painful for everyone when we get to October 1st.
And so everyone is getting ready for this. Right now at Madison Health, how many people are on the team right now just trying to get this accomplished? Is it a lot of people?
It is. It's quite a great representation of different areas within Madison Health. We have between, 50 plus folks who are part of our core task force. And so each of us is kind of focused on different aspects of the project. We have some people who are looking at the technology pieces. We have some folks who are really looking at that whole revenue cycle and the impacts there. Another team that's really focused on making sure that the coders have been trained and that they're certified and have some practice opportunities. We have some other folks who are focused on trying to make sure that the physicians have the education and the support they need as well.
How well is it going with the physicians?
Well, it is getting there, but I think we're making some inroads. We have identified several individuals to serve as physician champions, and we would love to have you serve as one of those.
Good. I'll have to do that, yeah.
So because we think by giving the physicians a lot more training opportunities, giving them some education, giving them a peer who can really kind of go through the process first, and then help to kind of, I hate to say hold the other's hands,
Yes.
but to really help them to kind of make that transition. So we're excited to do that.
Just talking about this, a lot of physicians are employed by different healthcare entities. Maybe it's not so hard for them. Maybe not. If you're a Navicent physician, does Navicent sort of take care of it for you? If you're an employee of Navicent, or
Yes, they will be.
and a private physician, however, has to depend on his or her own, abilities to get this accomplished.
Well, we actually are opening, one thing that's unique about Navicent that other organizations are not necessarily doing is they're making their training available to not just their employed physicians, but also to the private and community physicians. So if you are an affiliated physician with Navicent, you have a chance to come in, get education, get some training,
Yes.
get additional information as well.
Well, what happens, there are some country doctors out there, and the people that are out there, and they're sort of family practice doctors in a rural area. They're sort of looking after the rural population. How burdensome is this change in the system going to be on that doc that's presumably waking up in the middle of the night to, minister to sick country folks? How hard is all that? And has the government done anything for people in that position?
Well, it's definitely going to be a significant change, but CMS has actually taken a step this time around that I think has been really helpful. They put together a plan that any physician can go out. I think they call it their small physician portal, the Road to 10.org is where you can access it. And so by going out to that website, you can actually download a project plan, a task plan, so that you know the steps that you need to take to help you get through that remediation process. There are webinars, they're doing education across the country to kind of get the word out and educate the providers and office staff about what's happening with ICD-10 as well.
How hard is it? I mean, just to speak frankly on this, I mean, presumably the alphabet has increased enormously. Now, the stories that I've heard is that a lot of it's true enough that maybe there's a limit to what can be put on the old code, but there's some simplicity in it, and presumably there's not any, that I've ever heard of, any kind of difficulty with people, that code causing any kind of terrible errors in reimbursement arrangements. Maybe there are, but is the code so broken right now in regards to reimbursement arrangements? So is Navicent suffering that right now because of the ICD-9? Now, presumably in the future it might, and it might, but right now, is there suffering going on with the old system?
You know, I can't really speak if any specific provider is suffering because of the ICD-9 codes, the old codes. What I can tell you, though, is I really believe that with the transition to ICD-10, that it's going to actually make it a lot more transparent about the total condition of a patient. You know, one thing that I thought was really exciting when I first started learning about ICD-10 is that now you have codes that can help to represent social conditions or social status. So if someone is a smoker, if someone is not taking their medication, we actually have a lot more codes now so that we can report that. And you can maybe have to show why one case is more complicated or why maybe the recovery didn't progress as intended. So I thought that was an exciting change with ICD-10 that we hadn't really seen before.
Yes, I mean, you know, I don't want to be too, what can I say here, you know, questioning, but you know, looking at this, so okay, right now, what occurs when compensation happens, as I understand it, is there is a complexity number that occurs. So if you're going to be reimbursed and the person we have a toe amputation and the person stayed in the hospital an extra day, the reimbursement can be okay if you say the person had pneumonia or, I don't know, a diabetic or something. So the way that coding occurs has a tremendous impact on compensation arrangements, particularly for the hospital. I mean, particularly for hospitals. So it turns out to be a big deal.
Yes, it is a big deal.
And is it, just to pursue what you said here, so the coding is an important issue, and it would give say a hospital or a tertiary care organization more ability to say, well, we need more money because of the additional problems that occur.
Yes, I think the great thing about it is that it really does have to highlight the true, I guess I would call it severity of illness of each case, whereas today you may not be as clear why one patient was sicker.
Right.
Exactly.
Now, just to talk about this, so for the people to sort of understand what happens when a patient is in the hospital and they're pretty sick, there are coders that are employed by the hospital that basically, if I can understand this, they look at the patient's chart and they sort of fill in the blanks. The person was diabetic or had, I don't know, whatever, leukemia, and they put all these codes in there, and the reimbursement the number that comes back for the hospital depends on how extensive the coding is or how sick the patient was.
That is a pretty good summary. What the coders do, they actually take the physician's documentation and they actually review it to help them with extracting the codes from that process. And based on that documentation, that's the step they do go through and apply the codes based on that. So it's all driven actually by the physician's documentation.
Yes. So there's going to be some pressure on the physician.
Yes.
Well, it's one of the things, just to ask you mentioned socioeconomic status. So if a patient is in the hospital, who's going to say what the patient's socioeconomic status is in this coding arrangement? And presumably it's going to be of some consequence, but how would you judge something? Is it your income? You say, well, how much money did you make last year? I mean, is that what happens?
Well, no, it's actually not I wouldn't say the socioeconomic status, but if, for example, say a patient is not taking all of their prescribed medication, and as a result of it, they had to be readmitted, you now have a code that can show that the reason they're, I think they call it underdosing, is because of financial reasons. which
Really?
you know
Wow.
is significant. And so with that, hopefully what will come as a result of that, we have an opportunity maybe to point that patient to other ways that they could get care,
Yes.
other ways to get lower cost
Yes.
medication,
Yes.
etc.
Well, now, one of the things that at least I've done before is, and I've made, these codes, I've said, okay, poo-pooing the codes, but getting these codes on a national basis really is pretty important. So from looking at, I think it's really pretty interesting data to say, well, this is the amount of money spent on this particular code. So you had this code, you had, I don't know, let's say heart failure. I mean, that rubric is, far too simple of a thing to say, but I'm just going to say it, heart failure. So that's one code, and you can get a lot of information around the country of how effectively it can be used. So coding for research purposes would be a big deal.
Absolutely.
Now, what about coding errors? So if we have all these, let's suppose that a person, I mean, it seems to me the system still has a human interaction.
Yes.
So what happens if things are inadvertently miscoded by someone, a person is readmitted, and firstly, maybe the person we're just not able to extract the information, but somehow a mistake is made on the coding. How is that caught, and what does it mean, and isn't the system still have that problem attached to it?
It does. It does have the opportunity for us to make errors. But one of the things we're trying to do to try to prevent that is that we're giving the coders opportunity to practice, giving them a lot of intensive training. And then in addition to that, we're setting up audit and review processes so that we can try to catch some of that and then re-educate as needed. So that way they're as prepared as they can be for this change as well.
Wow, it's pretty complicated, and the government is overseeing this whole process, are they not? But also insurance companies.
Yes.
So the insurance companies are using these codes the same way the government would. Is that correct?
I believe so, yes.
Yes. Wow.
Fair statement.
Is the medical center adding additional employees? I know you said there are 50 people there now, but is the complexity of the coding going to mean there'll be additional people doing that, or do you know?
Well, one of the things that we're looking at right now is how it's going to impact our workflow and productivity. So currently, we're actually just trying to streamline as best we can.
Yes.
So that we can make things as efficient and try to control those costs for now.
Now, just to ask this question, it's sort of a big government thing, and I'm all in favor of appropriate government interface. But what happens if there's some kind of enormous screw up here, or the system needs to be revised? Is there some kind of methodology? So we're in Macon, Georgia. Is there some way we can communicate to some official, presumably in Washington, say this is screwed up here. Don't do this. I mean, you're able to crosstalk, or what? In October, are we going to be able to push buttons and say this is bad, fix it? Any comments?
I haven't heard of any process like that. But one thing that is occurring is a lot of different organizations are surveying providers, they're surveying physicians, hospitals, health plans, just checking probably every couple of months to say, well, where are you? Do you feel ready? Do you feel ready for this change? So I think that's really helping to make sure that come October 1st, we all feel comfortable with going forward.
Yes. Wow. Well, that's quite a task. Now, with your family, just how did you get? We've got a minute or two left. How did you get into this line of work? How did you wind up doing this?
Well, I actually have been working in healthcare for the past 25 years or so, and just started out kind of working up through the ranks within healthcare entities. So it's something that I always had a fascination with healthcare. I actually had a desire at some point to go to medical school, but that didn't happen. So I love the business, love what I do, love working with the folks here in Macon. So it's been wonderful.
That's great. Well, we're delighted to have you in our part of the world. Thank you so much.
Thanks for
and
having
good
me.
luck with you. You've got a tough job there.
Thank you so
I
much.
wish you well.
Appreciate it.
Thanks a lot.
All
Thank you
right.
for being with us.
Thank you.